Today, Dr. Michael Macken will present a real-world case study of a patient with Lennox-Gastaut syndrome, or LGS, appropriate for treatment with EPIDIOLEX, cannabidiol, and review the efficacy and safety of EPIDIOLEX, cannabidiol in LGS. Please see important safety information throughout the video and full prescribing information via adjacent link. Indications. EPIDIOLEX cannabidiol oral solution is indicated for the treatment of seizures associated with Lennox-Gastaut syndrome, LGS, Dravet syndrome, DS, or tuberous sclerosis complex, TSC, in patients 1 year of age and older. Contraindication: hypersensitivity. EPIDIOLEX cannabidiol oral solution is contraindicated in patients with a history of hypersensitivity to cannabidiol or any ingredients in the product. The speaker is being compensated by Jazz Pharmaceuticals for this presentation as a member of the EPIDIOLEX Impact Speaker Bureau. This presentation was developed with input from clinicians in the epilepsy community and special consultation from our advisors. The presentation has been approved by Jazz Pharmaceuticals for promotional use.
Hi, I'm Dr. Michael Macken, neurologist and Associate Professor of Neurology at Northwestern University Feinberg School of Medicine. My focus is on the diagnosis and treatment of epilepsy. Today, I will walk us through a real-world case study of a patient with Lennox-Gastaut syndrome. We'll explore their medical history, diagnostic workup, and the role EPIDIOLEX played in their treatment journey. In parallel, we'll review the efficacy, safety, and dosing profile of EPIDIOLEX in the treatment of LGS. Now, let's review the patient case together. Our patient is a 32-year-old female marked by the onset of seizures at 3 years old. She experienced various seizure types including tonic, myoclonic, generalized tonic-clonic, and absence seizures at a frequency of 4 to 12 times per month, and her medical history reveals developmental delay. For patients with LGS, obtaining an accurate diagnosis can make all the difference. A diagnosis can help when setting expectations and planning for future care, as well as with accessing tailored treatment and providing personalized management based on the condition. Many patients may reach adulthood without a specific diagnosis, and there are unique challenges to diagnosing LGS, partly due to its varied presentation. By adulthood, seizure types and frequency may change, with seizures occurring less often during daytime in some patients and with increasing injuries from drop attacks. Cognitive impairment is present in up to 95% of patients, with motor impairment and gait deterioration becoming more apparent. In older patients, there may be a decrease in or disappearance of slow spike wave complexes, but other EEG abnormalities, such as paroxysmal fast rhythms, may be present. Signs and symptoms of LGS vary over time. If your patient exhibits some of the mentioned symptoms, reassess their medical history to determine if they have LGS. In 2019, the REST LGS tool emerged as a resource to help distinguish LGS from other refractory epilepsies. Major criteria included having 2 or more seizure types, seizure onset before the age of 12, a history of EEG with generalized slow spike wave discharges, and cognitive impairment since childhood. Minor criteria included persistent seizures despite trying at least 2 anti-seizure medications, a history of treatments such as vagus nerve stimulation, ketogenic diet, epilepsy surgery, evidence of seizure-related helmet use, head or face injuries, and a history of other EEG abnormalities. Let's return to our patient case and review the patient's EEG findings. The EEG reveals polyspikes with generalized and lateralized left hemisphere activity. Predominantly maximal at the frontocentral region, these polyspikes range from 40 to 60 microvolts, occasionally appearing throughout the record. Furthermore, sharp waves are observed over specific regions. Over the right temporal region, maximal at F8T4, these waves measure 70 to 120 microvolts. Simultaneously, in the left center temporal region, maximal at F7T7, sharp waves ranging from 50 to 150 microvolts occur in quasi-periodic runs up to 1 to 2 Hz. Now, let's examine the clinical criteria supporting the diagnosis of LGS in our patient. The EEG findings reveal characteristics consistent with generalized and multifocal seizures. The patient has a history of multiple seizure types, including tonic, myoclonic, generalized tonic-clonic, and absence seizures. Additionally, there's an ongoing developmental delay. The patient previously tried a ketogenic diet, vagus nerve stimulation, and multiple anti-seizure medications, but continued to experience uncontrolled seizures. As the patient had an established LGS diagnosis, she was considered an appropriate candidate for treatment with EPIDIOLEX. EPIDIOLEX was studied in a randomized, double-blind, placebo-controlled, multi-center phase 3 trial consisting of 2 studies with almost 400 patients with LGS. This trial was followed by an open-label extension. The primary endpoint was change in drop seizure frequency from baseline versus placebo when added to current treatments in LGS. The clinical trials of EPIDIOLEX involved a broad range of patient types, including pediatric and adult patients, as well as patients taking various concomitant anti-seizure medications. In the LGS trials, patients spanned from 2 to 55 years old, with 32% falling within the age range of 18 to 55. In studies 1 and 2, the median percent reduction from baseline in the frequency of drop seizures was significantly greater for both dosage groups of EPIDIOLEX than for placebo. In a post-hoc analysis of the clinical trials, reductions in seizure frequency were reported as early as day 6. Notably, the 20 milligrams per kilogram per day dosage resulted in slightly greater reductions in seizure rates than the dosage of 10 milligrams per kilogram per day, but with an increase in adverse reactions. Now, let's turn our attention to the potential therapeutic partnership between EPIDIOLEX and clobazam for patients with LGS. In the LGS studies for EPIDIOLEX, 49% of patients were taking concomitant clobazam. Both are indicated for treating seizures associated with LGS, and EPIDIOLEX and clobazam share a bidirectional pharmacokinetic relationship. Each agent affects the active metabolite of the other without affecting parent drug levels. In the 2 LGS trials for EPIDIOLEX, patients in both dosage groups demonstrated a significant reduction in monthly frequency of drop seizures compared to placebo. In a pre-specified exploratory analysis of patients taking a combination of EPIDIOLEX and clobazam, patients receiving concomitant clobazam experienced greater monthly reduction in drop seizures than those taking placebo. Please note, combining EPIDIOLEX with clobazam may increase the risk of clobazam-related adverse reactions. Notably, EPIDIOLEX reduced seizure frequency by greater than or equal to 50% and greater than or equal to 75% in more patients than placebo. In LGS Study 2, 25% of patients in the EPIDIOLEX 20 milligrams per kilogram per day group achieved a 75% reduction in drop seizure frequency, demonstrating an 8-fold greater efficacy over the 3% observed in the placebo group. 11% of patients in the 10 milligrams per kilogram per day group achieved the same reduction. A 50% reduction in drop seizure frequency was achieved by 39% of the patients in the 20 milligrams per kilogram per day group, 36% in the 10 milligrams per kilogram per day group, and 14% in the placebo group. In LGS Study 1, more patients achieved greater than or equal to 50% and greater than or equal to 75% reductions in drop seizures when treated with EPIDIOLEX 20 milligrams per kilogram per day than placebo. Across the LGS studies, more patients experienced seizure freedom in the EPIDIOLEX treatment groups than placebo. Additionally, patients with LGS experienced a sustained reduction of drop seizures over 3 years in an open-label extension study. EPIDIOLEX also demonstrated a long-term safety profile similar to the pivotal trials for LGS, Dravet syndrome, and tuberous sclerosis complex. Furthermore, patients using both clobazam and EPIDIOLEX saw a notable decrease in seizure frequency compared to those on placebo, as shown in a pre-specified exploratory analysis. Across both Study 1 and 2, 55 to 56% of patients taking EPIDIOLEX 20 milligrams per kilogram per day experienced a greater than or equal to 50% reduction in seizures. Similarly, 41% of patients experienced a greater than or equal to 50% reduction with EPIDIOLEX 10 milligrams per kilogram per day. In both studies, 31 to 36% of patients on EPIDIOLEX 20 milligrams per kilogram per day achieved a greater than or equal to 75% reduction, while 11% experienced the same reduction on 10 milligrams per kilogram per day.
Important safety information. Warnings and precautions. Hepatic injury. EPIDIOLEX can cause dose-related transaminase elevations. Concomitant use of valproate and elevated transaminase levels at baseline increase this risk. Obtain transaminase and bilirubin levels prior to starting treatment at 1, 3, and 6 months after initiation of treatment, and periodically thereafter, or as clinically indicated. Resolution of transaminase elevations occurred with discontinuation of EPIDIOLEX, reduction of EPIDIOLEX, and/or concomitant valproate, or without dose reduction. For patients with elevated transaminase levels, consider dose reduction or discontinuation of EPIDIOLEX or concomitant medications known to affect the liver, e.g. valproate or clobazam. Dose adjustment and slower dose titration is recommended in patients with moderate or severe hepatic impairment. Consider not initiating EPIDIOLEX in patients with evidence of significant liver injury. There have been post-marketing reports of cholestatic or mixed patterns of liver injury. Elevated ammonia levels were reported in some patients with transaminase elevations, most taking concomitant valproate, clobazam, or both. Consider discontinuation or dose adjustment of valproate or clobazam if ammonia is elevated. Suicidal behavior and ideation. Anti-epileptic drugs, AEDs, including EPIDIOLEX, increase the risk of suicidal thoughts or behavior. Inform patients, caregivers, and families of the risk and advise them to monitor and report any signs of depression, suicidal thoughts or behavior, or unusual changes in mood or behavior. If these symptoms occur, consider if they are related to the AED or the underlying illness. Withdrawal of anti-epileptic drugs. As with most AEDs, EPIDIOLEX should generally be withdrawn gradually because of the risk of increased seizure frequency and status epilepticus.
It's important to be aware of the safety considerations when co-administering EPIDIOLEX and clobazam. More patients experience somnolence and sedation when taking EPIDIOLEX and concomitant clobazam. These effects were typically observed earlier in treatment and may diminish with continued treatment. Other CNS depressants, including alcohol, could potentiate the somnolence and sedation effects of EPIDIOLEX. Advise patients not to drive or operate machinery until they have gained sufficient experience on EPIDIOLEX. Pneumonia was observed more frequently with concomitant use of EPIDIOLEX and clobazam. Elevated ammonia levels have also been reported in some EPIDIOLEX-treated patients who also had transaminase elevations. Most cases reported concomitant use of valproate, clobazam, or both. Consider a reduction of dosage of clobazam if known clobazam adverse reactions occur. Turning back to our patient, in July 2019, the patient initiated EPIDIOLEX treatment, starting at a dosage of 5 milligrams per kilogram per day, administered as 2.5 milligrams per kilogram twice daily, with gradual titrations to achieve therapeutic levels. The patient initially experienced fatigue, which improved with clobazam dosage reduction. Like this patient, 22% of the patients that were on concomitant clobazam with either dose of EPIDIOLEX reported a dose reduction of clobazam during the LGS studies. Let's review the safety profile of EPIDIOLEX across LGS and Dravet syndrome trials. The most common adverse reactions that occurred in patients treated with EPIDIOLEX at an incidence of at least 10% and greater than placebo were somnolence, decreased appetite, diarrhea, transaminase elevations, fatigue, malaise and asthenia, rash, insomnia, sleep disorder and poor quality sleep, and infections. Hematological abnormalities, decreased weight, and increased creatinine levels were also observed in these studies. The rate of discontinuation for any adverse reaction was 2.7% for patients taking EPIDIOLEX 10 milligrams per kilogram per day, 11.8% for patients taking EPIDIOLEX 20 milligrams per kilogram per day, and 1.3% for patients on placebo. The most frequent causes of discontinuation were transaminase elevations and somnolence, sedation, and lethargy. Now let's review liver enzyme monitoring. Ongoing liver enzyme monitoring is recommended during treatment with EPIDIOLEX because EPIDIOLEX can cause dose-related elevations of liver transaminases. In LGS and Dravet syndrome studies, the incidence of transaminase elevations exceeding 3 times the upper limit of normal was 30% with patients treated with EPIDIOLEX plus clobazam and valproate, 21% with EPIDIOLEX plus valproate without clobazam, 4% with EPIDIOLEX and clobazam without valproate, and 3% for EPIDIOLEX without valproate and clobazam. Elevations resolved with discontinuing or reducing the dose of EPIDIOLEX and/or concomitant valproate in about 2/3 of the cases. In about 1/3 of the cases, they resolved during continued treatment with EPIDIOLEX without dose reduction. Transaminase elevations typically occurred in the first 2 months of treatment initiation. There were cases of transaminase elevations associated with hospitalization in patients taking EPIDIOLEX. Risk factors for transaminase elevation include concomitant use of valproate and, to a lesser extent, clobazam, increased EPIDIOLEX dosage, and elevated baseline transaminases. Ongoing monitoring of liver transaminase levels is recommended for patients on EPIDIOLEX. Monitor within 1 month following changes in EPIDIOLEX dose, addition of, or changes in medications known to impact the liver. If signs of hepatic dysfunction appear, measure serum transaminases and bilirubin promptly and interrupt or discontinue EPIDIOLEX as appropriate. Consider reducing or discontinuing EPIDIOLEX and other liver-impacting medications in patients with transaminase levels greater than 3 times the upper limit of normal and bilirubin levels greater than 2 times the upper limit of normal, or sustained transaminase levels greater than 5 times the upper limit of normal. Now that we've reviewed efficacy and safety data for EPIDIOLEX, let's review the recommended dosing. EPIDIOLEX can be flexibly dosed to optimize tolerability and response in patients with LGS. The starting dose is 5 milligrams per kilogram per day, to be increased in weekly increments of 5 milligrams per kilogram per day as tolerated. The maintenance dose is 10 to 20 milligrams per kilogram per day. In patients with LGS or Dravet syndrome, administration of doses higher than 10 milligrams per kilogram per day resulted in greater reductions in seizures, but with an increase in adverse reactions. Let's turn our attention back to the patient as of February 2024. The EPIDIOLEX dosage stands at approximately 10 milligrams per kilogram per day, administered as 5 milligrams per kilogram twice daily, complemented by clobazam at 10 milligrams. In late 2023, the patient experienced a slight uptick in seizures that resolved with a small increase in EPIDIOLEX dosage. The patient has experienced a substantial reduction in seizures since the initiation of EPIDIOLEX. Regular monitoring for fatigue is ongoing. The patient's appetite increased since the reduction in seizures. Notably, the concomitant use of EPIDIOLEX and clobazam has contributed to its reduction of seizures in the patient.
Important safety information continued. Adverse reactions. The most common adverse reactions in patients receiving EPIDIOLEX, greater than or equal to 10% and greater than placebo, include transaminase elevations, somnolence, decreased appetite, diarrhea, pyrexia, vomiting, fatigue, malaise, endosthenia, rash, insomnia, sleep disorder and poor quality sleep, and infections. Hematologic abnormalities were also observed. Pregnancy. EPIDIOLEX should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. Encourage women who are taking EPIDIOLEX during pregnancy to enroll in the EPIDIOLEX Pregnancy Surveillance Program and the North American Anti-Epileptic Drug (NAAED) Pregnancy Registry. Drug interactions. Strong inducers of CYP3A4 and CYP2C19 may affect EPIDIOLEX exposure. EPIDIOLEX may affect exposure to CYP2C19 substrates, e.g., clobazam, diazepam, stiripentol, orally administered PGP substrates, or other substrates. See full prescribing information. Consider dose reduction of orally administered everolimus with appropriate therapeutic drug monitoring when everolimus is combined with EPIDIOLEX. A lower starting dose of everolimus is recommended when added to EPIDIOLEX therapy. Concomitant use of EPIDIOLEX and valproate increases the incidence of liver enzyme elevations. Pneumonia was observed more frequently with concomitant use of EPIDIOLEX and clobazam. Dosage adjustment of EPIDIOLEX or other concomitant medications may be necessary. Please read the EPIDIOLEX full prescribing information for additional important information.